Good afternoon, and thank you, Gaurav, to have asked me to participate in the course. Quite a bit of what I want to say is covered, but I'm going to show even something more basic as to how to put the hooks and how to remove the hooks. Everybody tells you that you place the hook, but what is important is how to do it. But so we'll try to cover both the ring and the hook, so we're going to go a little fast in this. Now this is a good way. These are the Gresha-Bayer hooks. You have to place them. You can see it's like a rectangle. So you can cause a diamond, you can cause a rectangle, or you can cause a square. But you need this amount of space. So look at the placement. This placement has to be very, very good. If you place them well like a rectangle, you go ahead and do your phacoemulsification, do your CCC, and that's all fine. Do your IA and you put a lens implant. And then comes to the removal of the hook. Watch this. It's a hook, right? So when you try to pull it out, it sometimes gets inside the internal lip of the cornea and it can rip your cornea. So be careful. You have to actually turn your hand like this so that it comes straight line and it is in the line of the wound, and you sometimes even have to rotate. You can occasionally see me that I'll be rotating this part and then rotating it, make it sure that it is parallel to your whole wound. Okay? So you keep rotating it till the hook is parallel and then you can pull it out. So that's one way of doing. I'll show you many ways of removing the hook out of the eye. So this is one way of doing it. Now suppose you don't place these hooks in the right position. It can happen. Okay, it's an error. Now see what's happened. So instead of putting this at this o'clock position and this inferior hook at this o'clock, I've kept it at a wrong position. Now suddenly your surgery becomes tough. Ideally, if you are not that experienced, it's a good idea to put a fifth hook here and take the iris away. It will make your life much more easier. But if you're an experienced surgeon, you can get away with this scenario. But this is an error in the placement of the hook. So it's very, very important that if you want a square or a diamond or a rectangle, whatever you want, the placement is very, very crucial. So this error you should take care when it comes to it. Now coming to the Melugan ring, I'm going to show you the other ring. So now this is another case of an iridodialysis. Now this was superior, so it's covered by the lid. Now this would interfere in our cataract surgery. So what I decided that the pupil dilates well here, and this area the pupil would not dilate. This is the area of the iridodialysis. It was superior. I'm sitting superiorly. So this again under topical anesthesia, we just do an aqueous xylocard exchange, and then we get our hooks to our rescue. So what I'm going to do here is place two hooks. These are iris hooks and not capsular hooks, which you have been seeing in the videos before. So just hold on to the iris. So you got your nice round large pupil. Once your pupil is large, you can easily go ahead and do your phacoemulsification. I went ahead and did put an endocapsular ring because not knowing exactly what would be behind the iridodialysis, this is just an additional safety point that we decided, went ahead and put an IOL after that. So this is how then the hooks which were placed. Now this is an interesting case where it's a small pupil for a triple procedure. Now I'm going to put four hooks in a different fashion, and I'll show you how to remove the hooks at the same time. So this is hook. Now we have to make 4 ports. This is the disadvantage of hooks. You need to make 4 ports. The ports have to be very properly made. They have to be linear. They have to have a good tunnel. Otherwise, again, they'll be shallow and there'll be problems in putting the hook. So the tunnel length in putting it. So don't forget, when you place a hook, again, it's a side port. It's not. It's an incision that you're doing, and it's like a side port. So it does need a good creation of a tunnel. So once you've made this, we go ahead and create one, and then put the other hook, then put the third one, and then put the fourth one. So you can see now I'm now creating a diamond. Once you put in 4 hooks, we have 2 options. Either the incision will be linear to one of the hooks, or the incision will be lateral or nasal or temporal to the hook. So here I have decided, here now after putting the 4 hooks, I'm just tightening them. And at this stage, the incision can be here, anterior to the hook, if this would have gone little posterior, or lateral or nasal, whichever you are used to. So here I'm going a little lateral to the hook to make the incision. This is all fine. You got a nice large pupil, safe phacoemulsification, do your CCC, phaco, IA, lens implantation, and then we come to removal of the hooks. Now watch, that part is different. Now these hooks are made by APA, no financial interest, but I'll just tell you how to do this. This is just insertion of the lens, which is not for this course. We go ahead and dial the lens into the place. Now what to do as far as the hooks? Hold the hook and remove the plunger, the white stopper which is there, remove it completely. Okay? And then, so I've removed the plunger. Now we have 4 hooks to be removed. Hold on to the hook and you have to get it parallel to your incision, and this is the one next to the incision. Again hold on to the hook, pull out the plunger. That's one part. Okay? remove it and disengage it from the iris. So you have to push it in towards the eye, rotate it so that it becomes horizontal or parallel to your incision, and rotate your hand like this. Once it out, it just comes out. So this is the trick. Make it parallel and just rotate your hand like this and it comes out. So this is one way of removing the hook. Now the one across the incision, which is at 6 o'clock position, again the same thing, hold on to it, remove the plunger, push it in towards the eye so you disengage the iris. And the other way of doing it is go through the main incision, hold on to the hook and just pull it out the other way around. So this is one more way of removing the hook instead of struggling at the other end. This is one more way of doing it. And this is the nasal one. Again, remove it and go ahead, push it in towards the IOL. Go in, take the forceps through the main incision, and again you can remove it through the main incision. So this is some of the simpler ways of removing the hooks that we have placed. I'll go now to the part of the ring. Now you've seen the inventor do it, and we all try to copy him. And what here is one method where you can put in 4 parts of the ring onto the iris. One thing you have to remember, you need a little large incision. The 2.2 I think is now come to India. We are using the larger one. So now I got the one across the incision. So there's one loop which all goes onto the iris. There's a nasal and a temporal, and there is the subincisional. So how to get all 3 in one shot? So we've already engaged the iris across. At this stage, what you have to do is tilt your hand a little to the right, tilt your hand a little to the left, and keep watching the iris at the same time. Look at the iris, it's getting engaged onto the loop. Look at the iris, it's getting engaged to the loop. And look at the other side, and now tilt your hand to the temporal side, and now I got 3 loops in the iris at the same time. So a little tilt, a twist of your arm that gets you do this. There's one more method of actually when the loop comes out, you can actually take a T and put the 4th one at the same time. So in one attempt, you have to get all 4 into position. So that's also quite possible as far as the Mulligan ring goes. So now the last one, how to put this in. Okay, this is a Bessett's Y or a Sinskey hook. Now I recommend that both the instruments are wrong. Don't use a Sinskey hook, don't use a Bessett's Y, because what sometimes happens, it may slip, it may go behind the iris. The ideal thing to use is a T, and what the temporal and the inferior. I've left that all onto the iris. Put in little viscoelastic, get the plate of the plunger below the loop. Make sure that the whole loop is above the plunger. Then retract. When you're retracting, make sure that the tip of the plunger is inside the incision. Don't withdraw at that level. So imagine that the whole thing is inside, and now I'm withdrawing. At this stage, you can sometimes have the loop getting engaged into the plunger. Be careful. So you can then go in with a Sinskey hook through the side port and depress the loops superiorly, press it towards the steel plate plunger, and withdraw the plunger, and that disengages your inferior loop automatically. So you just need to remove one loop and the whole loop comes off. So it's quite easy to do, and now this can also happen. Now this is something very interesting which I wanted to show, that when you're putting it the 3-4, and now see what happens. I'm now using a Sinskey hook, and I told you don't use a Sinskey hook to put in the sub-incisional loop. Watch what happens. I've left it and I think I'm in control. Now it's gone behind the iris. So this can also happen, that if it goes behind the iris, now again your Bessett's Y will come to your rescue. They go around the bar, get it out, and then you have to hold on to it and bring it anterior. So again, you need to hold the loop when you are engaging the superior sub-incisional loop, and the best instrument according to me is either what Boris is using or a T, which will give you a good grip onto that part. So this is how we do. Now one more interesting case, which is the last case I'm going to show you. We still have 26 seconds. Now this is one thing you should never do if you are not that much experienced. Now you can see 1/4 of the cataract has been removed. You can see 3 and the 1 is disengaged. To put in a Mulligan ring after you've begun phacoemulsification is one of the most difficult things to do, because you can get onto the rhexis and complications can happen. Now if you have a vitrectomized eye, or if you have a patient with high myopia, okay, where there's hardly any vitreous, there's a fluid vitreous, see what happens to the ring when you go in with your phaco probe. Just watch this very carefully. I'm now again engaging all the 4 loops onto the iris, and see what happens when you go in with a phaco probe. Just watch that carefully. Watch this area, nasal and the superior, and see the area here. Now gone in, can you see this? Now I've gone in with the phaco probe. This loop has got disengaged because of the fluid that has gone in. It's a vitrectomized eye. The chamber becomes deep. This loop gets disengaged, this loop gets disengaged, and your iris, the Mulligan ring is off from the iris. Again, watch this very carefully. I'm going to show that again, and again it can come off. So when you go in again, watch this. Now you just start your phaco and everything gets disengaged. So this is one care that you have to take if it's a vitrectomized eye. This can happen. Now same thing will happen during IA. Now we are going in through IA. Watch this. Your phaco is done successfully. Now I'm going to do IA. Watch this. Luckily, when the pupil constricts, it gets back into the loop. So sometimes you need that man above also helping you, and otherwise all the loops can go behind the iris, and you have to then start bringing it forward. This is just the last few seconds, and now I'm doing my IA. And now last problem that you can face, I've done all this quite well, got the whole thing engaged. Now coming to lens implantation and dialing. Okay, so we have to put in the lens into the bag. You can see a nice rhexis, phacoemulsification done, IA done. All the 4 loops are in place. A little bit of cortex, which is subincisional, is being removed. Once that is done, I'm going to put a lens. Now what happens during lens dialing? Watch this. Be careful even at this stage. You think everything is done, you've done a successful surgery and everything is fine. Watch what happens when I'm dialing the lens. And I wonder how this really happened. It's a 3-piece IOL, foldable, going into the bag beautifully, no problem. It takes the loop with it. So this loop has again disappeared behind the iris, and now I have 3 loops in position, but this one has got disengaged. Again the same principle. Take your Bassett's Y, it anteriorly, bring it in the front, get in with your plunger. Very important as far as the plunger technique is concerned, be careful. The plunger is a little large. It can't strip the descendants at the level of the incision, but once you are in, make sure that the whole loop, here you can see that part of the loop is behind the plate. Make sure that the whole loop is in front of the plate so that you can see the whole blue loop in front of the steel plate there. Once you've done that, it's very, very simple. Just withdraw the plunger in. Here I have disengaged 3 parts of the nasal and the temporal haptic. You can see that. Press with the Sinskey hook from the top, the inferior one comes automatically. At the same time, the whole plunger is in position, and then do your IA to remove the viscoelastic. Thank you all for your attention.